Good morning, everybody. Thank you so much for joining me. I want to thank everybody from the medical students to the residents to any nurses or staff that may be watching for all of your efforts during this intense pandemic. What I wanted to talk about today is a brief introduction to sublingual immunotherapy. A little background about myself. My name is Monica Patadia. I'm an associate professor at Loyola University in Chicago. I am a rhinologist by training, a fellowship trained rhinologist. I started allergy and really learning about allergy and practicing allergy about a decade ago. And I largely credit the AAOA, which is the American Academy of Otolaryngologic Allergy, for teaching me pretty much everything I know, combined with experience over time. I have no financial disclosures. One big comment is that the aqueous antigens that are available in the US are not FDA approved for sublingual immunotherapy, and we'll get into that. So this is all considered an off-label use. And again, I did want to credit the AAOA because they are truly the backbone for my learning of otolaryngologic allergy and a great support. So if anyone is interested in learning more about this topic, I encourage them to go through our academy and go to the AAOA as well for various courses. So we have some goals of this talk here. The biggest goal is for everyone to understand the background and safety profile of sublingual immunotherapy. I'd like everyone to understand evidence that does support the efficacy of sublingual immunotherapy, recognize the potential benefits of SLIT, and then identify some possible areas and needs for future research. There's always need for additional research. So let's start with some background. Allergen immunotherapy has been studied and practiced since the early 20th century. And what I'm talking about with immunotherapy is mostly subcutaneous immunotherapy, which is SCIT. We'll call that SCIT, versus SLIT, which is the sublingual immunotherapy that I'm going to discuss today. What does immunotherapy mean? Well, immunotherapy essentially means that we are giving regular and sequential higher doses of administration of something that a patient may be allergic to induce some sort of immune tolerance. When you're doing subcutaneous immunotherapy, you're actually starting with extremely low doses oftentimes based on their testing results. And then you're building them up weekly to get to what's called a maintenance dose. I always tell patients, if I started you on that maintenance dose right away with an injection, you quite possibly could have a severe reaction. So we have to start really low and then build that up. There's various administration routes. We could do subcutaneous immunotherapy, which is what I just talked about, SCIT, SLIT, which are the drops under the tongue. Other things have been investigated, and maybe these will be in our future, oral, bronchial, nasal immunotherapy. Although at this point in time, those are not necessarily considered mainstream. So I want to start with just some questions. Just think about them in your head. So SLIT offers all of the following except the convenience of home immunotherapy, a high safety profile, no risk of anaphylaxis, or a lasting benefit in symptom control beyond the active treatment period. So SLIT offers all of the following except. And we'll answer that question as we move through this talk. I'm sure you'll know the answer. So let's just talk about immunotherapy in general and the benefits behind it. We know that patients that undergo immunotherapy in general, again, subcutaneous immunotherapy, have efficacy and it's safe. There's long-term benefits. Patients that undergo immunotherapy are thought to have long-term benefits for up to about a decade after their immunotherapy. We realize therapy can result in prevention of asthma and new sensitization. So for example, a child that has immunotherapy under the age of 6, it may reduce their risk of developing asthma over time. We also know children that are monosensitized over time can develop polysensitization, and the thought is immunotherapy may reduce that risk. Does immunotherapy work? Well, when patients come to my office and ask if allergy shots are worth the time, I do say that the success rate is approximately 90%. But what that means, I'm very clear to patients. Just because you undergo immunotherapy, it does not mean that if you're allergic to a cat, for example, that you can now get 10 cats and that you will not have a single symptom. Efficacy simply means that there is symptom reduction, decreased medication use, and quality of life improvement with time. And it's about 90%. So the majority of my patients that have year-long symptoms come in a year later, or actually, I mean, usually as soon as 2 or 3 months later, stating that they used to be miserable during the spring and now they no longer notice much. They used to need to be on 4 medications and now maybe they take 1 as needed. So that is considered successful immunotherapy. A brief history of sublingual immunotherapy. It really started in the early 1900s, and at that time, patients were reacting. They were sneezing, itchy eyes, watery eyes, and people thought that there may be an airborne toxin, and they were trying to develop a vaccine for this airborne toxin. Ultimately, that's how we came up with immunotherapy. In the 1940s, SLIT was actually performed in the US based on what's called skin endpoint titration results, a term we no longer use. The big thing and the big break for sublingual immunotherapy actually happened in 1986. And what happened in 1986 is that the British Committee of Medicine they placed a report out stating that there had been 26 anaphylactic deaths, and they were truly concerned. And at that time, they recommended that anyone performing immunotherapy in England needed to have patients wait in their office for 2 hours after the injection and also have full CPR abilities. So at that time, it made subcutaneous immunotherapy rather not approachable to the average physician. And hence, sublingual immunotherapy really started taking off in many of the European countries. The first sublingual immunotherapy randomized controlled trial occurred in that same year. It was on house dust mite. The World Health Organization endorsed sublingual immunotherapy in 1998. And in 2014, we'll discuss this briefly later, the first FDA-approved sublingual immunotherapy tablet in the US was formed. So I mentioned this briefly, but what are the methods by which you can administer immunotherapy? Well, we talked about the most common one is SCIT, which are allergy shots. That's what we're pretty much all used to. We're talking today about sublingual, which are allergy drops under the tongue. But the alternative routes include the following: intranasal, bronchial, oral. So why are those not used? Well, my nose is itching just at the thought of intranasal immunotherapy. It's a great concept. It's not there yet. Ultimately, we found patients had too many nasal symptoms, extremely bothersome symptoms. Bronchial route of immunotherapy at this time is thought to have an excessive risk with only a marginal improvement in symptoms. And then oral immunotherapy. There are companies that market toothpaste, for example, and there is efficacy. However, in general, the concern for oral immunotherapy is that it is swallowed, and there is a concern for marginal effectiveness as well. So the mechanism of sublingual immunotherapy. I always say that as otolaryngologists, this is not necessarily what we're excited to see is the science behind things. Kind of takes us back to our medical school years. So I'll go through this just briefly and tell you big concepts. Ultimately, the allergen is taken up by our oral dendritic cells in our what's called our mucosa, sublingual mucosa. Migrates to the lymph nodes. Ultimately, you have an increased T regulation response of CD4 positive cells, CD25 positive cells, and you have the increase in all of these TGF-beta, interleukin-10, interleukins, and cytokines, which are thought to suppress specific T cell responses. And the big thing I like everyone to focus on is what's called this shift in the Th2 to Th1 balance. And that's thought to be an indicator of immunotherapy efficacy. Th1 in general, I want all of you guys to think of Th1 as what's called a cell-mediated immunity, versus Th2 is more related to interleukins that mediate antibody responses for allergy. All right, so I think of Th2 as an allergen response, Th1 as a cell-mediated response. If someone is highly allergic, think of them having a higher Th2 to Th1 balance. After immunotherapy, the thought is there is a shift in the balance such that there is now an increase in the allergen-specific Th1 and a decrease in the Th2. Just putting this in pictures, what's happening with sublingual immunotherapy? Most of you hopefully are familiar with subcutaneous immunotherapy, where ultimately you have an IgE-mediated response, and ultimately when an allergen is injected into the skin, it is taken up by mast cells, and you ultimately have an upregulation of your regulatory system. So the same thing with sublingual immunotherapy. The allergen is introduced, we introduce it to the floor of the mouth, right below the tongue, sublingual. Allergen's taken up by the mucosa. It adheres there very quickly. The allergen is then captured by these dendritic cells. And right down here, you actually see these mast cells and eosinophils. So in that lamina propria, and then within the submucosa, lays everything that is also there within the skin. And the thought is that the oral mucosa, the dendritic cells, may actually have a higher expression of MHC, major histocompatibility. And then ultimately, there's a migration to draining lymph nodes, and the thought is it can alter the immune response. So I'm comparing sublingual immunotherapy to subcutaneous quite a bit. And that's because subcutaneous is what's FDA approved, and that's considered our standard for what we offer patients. So subcutaneous immunotherapy, let me start by saying, is our gold standard. It is an excellent option. And when patients come to my office and they say, I want the best possible immunotherapy, I recommend subcutaneous immunotherapy. But I remind them, I say, it's a huge time commitment. You're coming in my office, you're coming in once a week, every week for a few years at least. They have to do what's called build-up immunotherapy. And then once they get to that build-up, they're on weekly injections of maintenance immunotherapy. After their injection every week, they're staying in the office for 30 minutes post-injection, and they're staying there to observe for an anaphylactic reaction. They can do whatever they want during that time. I say they can do their work on a laptop. They can even eat their lunch. They just can't exercise in our office because you can't exercise within a few hours before or after immunotherapy due to an increased risk of anaphylaxis. But that's a huge barrier for patients. They say, you want me to do what? Come in every week for the next several years? A lot of people don't have time for that. I mean, think of you as a resident or a medical student or as a nurse, as a physician. Can you really give up an hour of your day once a week? In addition, there's an expense. Patients often have to come in every week. They may have to pay their copay. They may have to pay for parking. They may have to pay for gas. They may have to take time off of work. This can add up. Patients hate needles. Well, if you hate needles or you're someone that constantly vasovagals with an injection, subcutaneous immunotherapy may not be for you. Some patients have tried subcutaneous immunotherapy and they just can't tolerate it. They have soreness at the site. They're sick of getting needles. They want another option. You can also have local reactions, delayed local reactions, and there is a risk for anaphylaxis. And we're going to talk about this. There's also a risk for anaphylaxis with subtherapy, so that's not necessarily a completely fair comparison. However, the risk of anaphylaxis for subcutaneous immunotherapy, although much although rare in general, is a higher risk than compared to sublingual immunotherapy. All right, so let's talk about, let's go back here, the benefits for sublingual immunotherapy. Well, patients come in for their first drop under the tongue in the office, but then after that, everything's done at home. So they're able to give themselves drops at home. What I tell patients is you're trading off getting a shot in the office once a week versus giving yourself a drop at home, but giving it to yourself every single day for the next 3 to 5 years. Of course, no one could predict this before this year, but COVID-19 has truly made sublingual immunotherapy an excellent option for many of my patients. There were patients that were on subcutaneous immunotherapy, but now with COVID-19 and patients not wanting to come to the office, or the risk of coming to the office is too great for them, they are converting to sublingual immunotherapy. That way they can give themselves drops at home. They don't need to risk being in the office, having increased exposure to staff or increased exposure to anybody else that's in the office. Of course, there's no needles, drops under the tongue only. The big thing with sublingual, as I mentioned, is it is not FDA approved. Although it is considered to be safe and effective, it is not FDA approved at this time. So for that reason, it is not covered by the majority of insurance providers. So patients are paying an out-of-pocket expense. However, there are several studies, and I didn't want to go into all the studies. This is more of a general overview talk, but there are many studies that discuss that there truly could be a cost benefit for sublingual, because if you add up your co-pays, your cost of gas, your parking possibly at the office, your missed work, all of that compared to paying this out-of-pocket expense, and that cost is different for every office, just depends on what it costs in your area, but that can very well balance itself out. And for some patients, it may even be covered under their flex spending account, but I tell everyone to check with their providers. And patient safety, there is still a risk of anaphylaxis, but that risk is far reduced. And then again, it was interesting as I put this talk together, because of COVID-19, this was never considered a huge issue before, but truly now in this day and age, not coming to the office is a benefit because there's decreased office exposure. So let's go into another audience response question. Which of the following is true? Anaphylaxis does not occur with sublingual immunotherapy. No fatalities have been reported with sublingual immunotherapy. The incidence of fatal reactions with subcutaneous immunotherapy is 1 in 100,000. Or rush sublingual immunotherapy for peanut allergy is safe and effective. I'll give you all just a few seconds to think through that. All right. You'll learn the answer to that shortly as well. So sublingual safety. As I've already mentioned and alluded to, SLIT has an excellent safety profile. It is considered to be safer than subcutaneous immunotherapy. And it's safer because of the decreased risk of anaphylaxis. However, there is a higher local side effect risk. So this is something I do tell my patients, that when you perform sublingual immunotherapy, there is a high chance that you may have some itching or pruritus or some localized swelling under the floor of your mouth. Now that's completely different than subcutaneous immunotherapy. If with subcutaneous immunotherapy injections, you actually had swelling under the floor of your mouth, that would be concerning. However, again, think about SLIT. You are having a local response under the base of the tongue, on the floor of the mouth, and that is often expected. Despite these local side effects, it's thought that less than 2% of patients stop immunotherapy due to adverse reactions. If I gave you this talk before 2006, I could tell you that there have been no anaphylactic reactions for sublingual immunotherapy. However, as we all know, if you do something long enough, there's usually going to be a problem that is uncovered. So there was the first SLIT anaphylactic case that was reported in 2006. And since then, there have been some, although the incidence is quite low. There are no known fatalities to SLIT that I'm aware of. If anyone knows of one, please let me know. But the big thing is there is a risk of anaphylaxis. It's much lower than subcutaneous immunotherapy. There are no known deaths at this time. That being said, I still am super conservative with my patients. I do prescribe an EpiPen to all my patients that are on any form of immunotherapy, whether they're on shots in the office, the off-label SLIT that we compile in the office, versus the FDA-approved tablets. Any patient that is given any sort of immunotherapy should absolutely be evaluated for whether or not they're a good candidate for immunotherapy. I want to talk about the anaphylactic cases, the early cases of anaphylaxis from 2006 to 2009. There were 6 anaphylactic cases that were noted. 2006, the first reported case of anaphylaxis was a 31-year-old woman. It was her third day of a multi-antigen sublingual immunotherapy. It was not witnessed. We do believe it happened, but it's hard to really know. There was another one that same year, also a young woman, mid-30s. It was rushed latex sublingual immunotherapy. The office administered subsequent treatments at reduced doses without rush immunotherapy, and the patient did not have any further reactions. 2007, there was an 11-year-old girl. She had multi-pollen sublingual immunotherapy and a maintenance phase, but she did have a reaction that included lip swelling, GI symptoms, and it was during the peak pollen season. 2008, this is an interesting one, and I give this example to my patients all the time. 16-year-old girl, she had a 3-week break from her house dust mite SLIT. So what did she do? Well, she tried to make up for lost time by giving herself 6 times the dose. I remind patients of this story all the time because any patient that's on sublingual immunotherapy or any sort of immunotherapy needs to have an understanding of what they are doing. It needs to understand that they're actually challenging their body and they absolutely must follow the directions. If they miss a dose, I say do not do anything other than calling our office. Do not ever take double the dose. And that's a big one. I do remind patients of this story. 2009, there were cases of the first dose of Grazax, which is more of an FDA-approved tablet. And these patients were not, there's no escalation for these. And that's why it's recommended that for all sublingual immunotherapy, the first drop or tablet is given in the office. There was a comprehensive review in 2012, and overall there was 11 reported cases of SLIT anaphylaxis that were meeting the World Allergy Organization criteria. And the thought is that there's been 1 billion SLIT doses administered worldwide since 2000, and the rate of anaphylaxis is considered to be 1 case of anaphylaxis per 100 million SLIT doses. In comparison, the death rate for subcutaneous immunotherapy is thought to be 1 in 2.5 million, and the anaphylactic risk for subcutaneous immunotherapy is thought to be 1 in 1 million with World Allergy Organization grade 4 systemic reactions, or the rate of any sort of systemic reaction in general for subcutaneous immunotherapy is 0.1%. So how do we administer SLIT? And I just want to take a step back because the assumption in this talk is that everyone has been exposed to immunotherapy. But we talked about SCIT or shots in the office, FDA approved, that's the gold standard. There are 2 other options. There is what's called the FDA approved sublingual immunotherapy tablet. There's about 4 of those out right now. I'll touch on that briefly at the end. They're only brand names for now. And then there is what's called the sublingual drops. So what that means is We are making drops specific to what patients are allergic to in our office under sterile technique, or a third-party vendor is making these for patients, and the patients are giving themselves these drops via a dropper or a pump under their tongue. So how we make these are in the office. It's essentially 1 cc or 1 ml of each antigen that the patient has symptoms to and has been proven to have a type 1 hypersensitivity reaction to via testing. The testing can be done with skin testing or blood testing. We put in 1 cc of that antigen. There is data to show that sometimes you need to go higher than that, but if you do that, you need to proceed cautiously. And the big thing is the dosing of sublingual is far greater. It's anywhere from 5-fold to 500-fold greater than subcutaneous immunotherapy. So when my allergy nurse makes the injection vials versus the allergy drop vials, they are done on separate days, and they're done very carefully, because you would never want to mix up those 2 vials. That would absolutely be disastrous. When patients get these vials, they come in for their first drop in the office. They essentially place a drop. We have a little pumper. It's given right under the tongue. There's a 10-day buildup phase for sublingual immunotherapy. And after that, they're essentially on 5 drops daily for the next 3 to 5 years. When they take the drop, I tell them to just do it first thing in the morning or at night, whenever they're going to remember. You ideally don't want to swallow, hold it there for about 30 seconds to a minute, and then they can essentially swallow at that time. If they're having too many reactions after swallowing, we do say that it's okay to also spit out the antigen. We ask them to not have any food or drink for 5 minutes after administration. And again, that first dose is given in the physician's office. It's done for several reasons. Number one, it's just a review with patients, everything they should be looking for, make sure they understand the directions, make sure they know how to build up, making sure they have an EpiPen, and also monitoring for symptoms. We still observe them for the 30 minutes for that first dose, but after that, they go home and they just come and pick up a new vial every 5 weeks. And my nurse is excellent. She's constantly calling patients. She is checking up on them, and then patients come into the office anywhere from 1 to 4 months for follow-up. And again, during this pandemic, we can do follow-ups over the phone as well. If SLIT is administered for children, of course, there needs to be adult supervision. We've gone through everything else. So what are contraindications for SLIT? Can every single patient get sublingual immunotherapy? Absolutely not. There is a level of a need for understanding of directions. So a huge thing I look at is patient compliance. Not necessarily their education, but their ability to comply and understand directions. If I have a patient that has no-showed to my office 3 times for allergy shots, they're probably, they could be a SLIT patient if they have a good reason for missing it. If they say, listen, I'm a teacher, I'm very regimented in general, I just cannot make it into the office, well, then that might be a good option. However, if it's someone that says, well, you know what, I didn't come in for a month because I don't really have a good reason, and for 1 month I'm off of stuff, and then I come back to it 3 months later, that's not someone that I'm going to give SLIT an option to. I also make sure that they can follow directions in general. There are some patients, the majority of patients are pretty smart, but there are some patients that just don't understand things, or it takes them longer to understand things. And if you think they can eventually understand it with proper education and guidance, you're welcome to put them on sublingual immunotherapy. If you think they're at risk of being that patient that's going to quadruple their dose because they missed it, and they're going to end up with an anaphylactic reaction, well, then you have not done anyone a service by giving them sublingual at home. If a patient has severe or unstable asthma, you absolutely should not administer immunotherapy until that is stabilized. If they have a history of severe systemic reactions to injection immunotherapy, that possibly can make them at an increased risk of a reaction during SLIT. I do have patients that are on SLIT who have had a possible mild systemic subcutaneous immunotherapy, but there is an extensive discussion of risks and benefits, and we monitor those patients even more carefully. If a patient has eosinophilic esophagitis, the thought is you do not want to place them on sublingual immunotherapy for a risk of progressing that disease process. If they have inflammatory oral lesions, you want to hold on sublingual. And if a patient's on a beta blocker in general, we're extremely cautious to start them on immunotherapy due to the potential increased risk of immunotherapy, or excuse me, potential increased risk of anaphylaxis and the extreme difficulty in treating anaphylaxis while on a beta blocker due to unopposed alpha. So is SLIT effective? In general, absolutely it is. We test for various things, subjective measures, symptom reduction, medication use, quality of life assessments. And then there's objective measurements such as immunologic changes. Is the skin no longer reactive? How is your lung function? The problem with most studies for SLIT, and this is where we have the biggest room for growth on sublingual immunotherapy, is that there's substantial variation in the instruments used to measure these endpoints. Most offices have differences of duration, dose, escalation protocols. Are patients getting sublingual during peak seasons or continuously? In general, SLIT is effective for allergic rhinitis, allergic conjunctivitis. It's effective in adults and children. But the important note is this following. The majority of immunotherapy randomized controlled trials for SLIT are single antigen studies. And when I compound sublingual immunotherapy in my office, the biggest advantage we say to patients is that if you're allergic to a tree pollen and a ragweed and a dust mite, I can put all three of those antigens in the same vial for administration for sublingual immunotherapy. Are there studies to prove that multi-antigen immunotherapy is effective? Well, they're very limited, and that's really the biggest need for data and study in this field. Dr. Leatherman, this is a little bit of an older study, but he did review 36 studies, and 30 of 36 did demonstrate efficacy in symptoms, medication use, or both. It demonstrated efficacy during seasonal as well as year-round allergens. It improved rhinitis, conjunctivitis, asthma prevention. And this was true for weeds, grass, dust mites, trees. The mold data is a bit more questionable. And so if a patient comes to me for truly just a mold immunotherapy, we do have a true discussion on their expectations as well as my expectations. Dr. Lin in 2013 reviewed about 74 subcutaneous immunotherapy randomized controlled trials, 60 SLIT, and then 8 comparison studies. And the bottom line is this: for SCIT, your symptom improvement evidence for asthma, rhinitis, conjunctivitis, decreased medication use is all fairly high. However, for sublingual immunotherapy, it is still absolutely effective, and the strength of evidence is moderate to high. So what I tell patients is the following, because they say, well, if they ask me what is absolutely the best option, at this time I say, well, if you want the absolute best, and you can come in for a shot once a week, come on in. However, there are many patients I have, flight attendants, teachers, CEOs, people that travel, medical students, physicians, that cannot come in and commit to allergy shots. For those patients, those drops under the tongue are an excellent option, and I think that it's definitely better than nothing, and there's certainly moderate to high evidence of its efficacy. Before I end today, I wanted to just comment briefly on these SLIT FDA-approved tablets. I'm using brand names because that is what's available. But Oral Air, Ragwitek, Grastek, Odactra, these are all specific FDA-approved tablets for specific antigens, which is what's called monotherapy. So Odactra, for example, is effective against house dust mite. Grastek is for Timothy grass. short ragweed pollen, and then Greer it is a 5-grass tablet, but it's, you know, especially for just grass. So the big difference between these SLIT FDA approved tablets versus the SLIT drops that are compounded in the office is mono versus polyantigen administration. I do offer these tablets as well for the right patient. The biggest thing is to check a patient's testing results, discuss with them what their symptoms are, and just taking a step back. Not every patient that has any sort of allergy symptom, not every single patient that has had one sneeze needs immunotherapy. Immunotherapy is truly an option for a patient that has had symptoms for moderate to severe symptoms for 6 months or more out of the year, or is on multiple medications and would like to reduce their medication use or decrease their medication use, or is having increased symptoms over time. So for those patients, I'd like to summarize by saying that sublingual immunotherapy does have an excellent safety profile. There is still a potential for anaphylaxis, although that risk is extremely rare. SLIT is considered to be effective in allergic rhinoconjunctivitis and asthma in adults and children. There is some evidence supporting SLIT for preventative effects for asthma, as well as new sensitivities, and there are long-lasting effects. There is more research that is needed for multi-antigen therapy, and then any sort of non-respiratory allergy. This talk just touched the surface of immunotherapy. I strongly encourage any of you, if you're interested in learning more about otolaryngeal allergy, please go to the American Academy of Otolaryngology Allergy website. They have wonderful talks during this COVID pandemic. They also have Zoom and virtual discussions. And this is where I learned all of my allergy background. One more thing I'd like to end with. I am a rhinologist by training, as I mentioned, and not every patient that comes to my office is allergy tested or offered immunotherapy. Again, I like to think of myself as essentially a sinus surgeon. However, patients come in, we know 1 in 5 Americans have allergic rhinitis, and you cannot ignore those symptoms. If you are in otolaryngologic practice, you will see patients that have allergic rhinitis, and so just at least understanding the options is valuable, and patients will thank you for your comprehensive care. Finally, I'd like to end by saying thank you to everybody that's been here. Thank you for all the frontline workers and for everyone that's doing anything related to their part in COVID-19. Please stay safe. If anyone has any other further questions, thoughts, concerns, or wants to just know more about these options, feel free to email me. This is my work email address. Thank you so much.